Okay.
Can you hear me?
Yeah.
Okay.
Perfect. So welcome everyone today again to our CT and cardiac MRI lecture series. It's a pleasure today to have Linda Haramati that will be talking about atrial septal defects in adults of the role of MRI and CT in guidance therapy. So briefly, Linda initially trained in her med school here at Albert Einstein, and then she did her residency at Montefiore Medical Center, and then her fellowship at Columbia Presbyterian. She's board certified. She has been the division head of cardiothoracic imaging in the Department of Radiology since 1998. She's a member of the American Board of Radiology, and she's cardiac certified in that. And she has multiple presentations, multiple papers, and it's a great honor to have Linda today with us. Thank you very much, Linda.
Thank you for inviting me, and I acknowledge my collaborators in this presentation, Anna Bader from Yale and Stephanie Tan from Montreal Heart. And as Leandro mentioned, I am a radiologist, so we're going to be seeing some chest x-rays in this presentation and no echocardiograms, so don't be too surprised about that. We have nothing to disclose. The lecture outline is going to talk about atrial septal defects in general, where they are, and focusing on adult presentations. What are the treatment options and indications? And then most of the talk is going to be case-based, showing examples of the various types of atrial septal defects and lesions that are similar to atrial septal defects. So this is a diagram that's been adapted from the article by Summer et al. On pathophysiology of congenital heart disease in the adult, part 1, shunt lesions, published in Circulation in 2008. And it goes really very step by step through the pathophysiology. And as we know, when you're talking about congenital heart disease or any congenital anomaly in adults, we are seeing a different, more mild spectrum of disease because the more severe ones tend to present earlier on in childhood. The types of ASDs I'm going to be talking about, and some of the ones I might not talk too deeply about, Secundum ASD, which comprises 75%. Looking at the interatrial septum from the right atrial side, we see it here, number 1, right in the middle of the intraatrial septum at the fossa ovalis, can be associated with other anomalies, including partial anomalous pulmonary venous return and mitral valve prolapse. And number 2, primum defect, which is in the spectrum of endocardial cushion defect, which can be more severe. It comprises about 15% of ASDs, and we see it here posterior to the AV valves. It's frequently associated with a cleft mitral or left AV valve leaflet, regurgitation, and associated ventricular septal defect. Then the remaining lesions are hemodynamically similar to ASD, but they're not really considered true atrial septal defects because they're not exactly defects in the interatrial septum, although they result in interatrial communication. So number 3 right here, we see the superior sinus venosus defect. It's a defect in the sinus venosus at the SVC right atrial junction. It's about 10%, so it's pretty common, of defects, and it's associated with right-sided partial anomalous pulmonary venous return. Number 4, the inferior sinus venosus defect is actually a very rare anomaly at the IVC right atrial junction. And number 5, this is the orifice of the coronary sinus into the right atrium. And an unroofed coronary sinus, the roof of the coronary sinus can be absent or incomplete, and therefore there's a communication between the coronary sinus and the left atrium as it travels in the left AV groove. So also similar to an ASD pathophysiologically, that's frequently associated with a persistent left superior vena cava. Now I put patent foramen ovale on here because it is also a communication between the two atria. It's present in 25% of the general population, and it has a it's a flap valve, so it tunnels through the interatrial septum rather than a direct communication. And I'll be showing examples of that. In adults, when there's a shunt congenital heart disease presentation, ASD is about 1/3 of all cases. And as I mentioned, it has a milder disease spectrum than the pediatric presentation. However, the flow is generally left to right, with shunt increasing in adults due to decreased left ventricular compliance. And because of the decreased compliance due to comorbidities, symptoms will often develop in the 30s or 40s, or even later on in life. And I'll show you some examples of presentations kind of in the geriatric age range. And the symptoms can be very nonspecific: dyspnea, fatigue, recurrent respiratory infection, although paradoxical embolization is highly suggestive. Only a minority of patients who have atrial septal defect, even with adult presentation, develop pulmonary hypertension. So what's the role of imaging? I just wrote transthoracic and transesophageal echocardiogram. I'm not going to teach the cardiologists about echocardiography, but in my own bailiwick, shunts are often actually discovered incidentally on chest X-ray or chest CT performed to explore non-specific symptoms. So in some cases, it's actually incidental. The symptoms are unrelated, or in some cases, the symptoms are very non-specific, but they are related to the underlying shunt. And it's imperative to recognize these typical appearances when we see them, because even though they're typical, they're also difficult to recognize. And I'll show you some examples. If we know that there's a cardiac problem, we're going to do a more directed cardiac MRI, or in cases where MRI is more difficult to perform, we may do ECG-gated CT to answer specific questions, including anatomy and size of the defect, for treatment planning, although a lot of times that is done with transesophageal echo. Quantifying ventricular volumes and function, MRI is considered the reference standard for that, especially for the right ventricle, and right-sided cardiac volumetrics are very important when evaluating shunts. Retrospectively gated CT, we can also measure ventricular volumes and function, although the results are not exactly comparable to MRI, and it's a little bit less of a reference standard. When we look at the pulmonary to systemic blood flow ratio, which is another factor that's used in determining treatment, on MRI, we can directly measure the flow using phase contrast imaging. We can also evaluate the flow based on differences in the stroke volumes between the two ventricles, which is really our only tool if we're trying to estimate the QP/QS on CT, because there's no way of directly measuring flow. We have to just go based on the stroke volumes. And we also have the ability to look for additional cardiac and vascular anomalies, and CT and MRI are particularly valuable when looking at the extracardiac vasculature, which can be anomalous. So here we have a typical chest radiograph of a patient with an ASD. So this is an older gentleman, 70 years old. He doesn't have any known cardiac history, and he presented with chest pain. And he has a PA and lateral chest X-ray. And what we see on the radiograph is that the central pulmonary arteries are very dilated, but we also see markedly dilated peripheral arteries, and the arteries are sharp. So unlike in the case of congestive heart failure, where you see redistribution of flow, a lot of it is the venous congestion, and we see interstitial edema manifest as perihilar haziness. We frequently see pleural effusions. When we have the overcirculation or shunt vascularity related to a left to right shunt, this is the characteristic appearance. Prominence of the central and peripheral pulmonary arteries, very, very sharp. And this is characteristic shunt vascularity. And it's surprising, but it's true that on a semi-regular basis, we have the opportunity to make that diagnosis in radiology or to not make the diagnosis. Secundum ASD is the most common ASD. It's due to deficiency, perforation, or absence of the flap valve of the fossa ovalis or its muscular rim, and it has a female to male predominance, and that predominance is not just present in childhood, but it's present in adulthood as well. And the majority of ASDs that we diagnose in adults are women. Often it's an isolated anomaly, but it can be associated with syndromes such as Holt-Oram or Noonan syndrome. When it presents in childhood, it tends to be the larger defects, although you can hear them, you can hear murmurs from small defects, and their spontaneous closure of small ASDs is actually very common in childhood. However, adult presentation of ASD is not uncommon. And here's that same 70-year-old man that we saw before with his chest pain, and he had a CT scan in the emergency department to evaluate for pulmonary embolism, and he had no PE, but we can see that his main and right pulmonary arteries are markedly dilated. If we compare them with the aorta, even the right pulmonary artery is way bigger in cross-section than the aorta. And when we look at the heart, we see that the right ventricle and the right atrium are dilated. The interventricular septum is flattened, and we actually can see the defect in the interatrial septum. The interatrial septum is thin, and even on gated CT or MRI, it can be imperceptible at times. But here we actually see kind of a very sharp, abrupt end to the interatrial septum, and we can be confident that this is a secundum ASD. So what's the treatment for ASD? So the treatment, if it's indicated for secundum ASD, the current standard treatment is percutaneous if the lesion is amenable, and if not, surgical treatment if it's warranted. Other ASDs are typically treated surgically if they're warranted. ASD closure in adults in a systematic review in 2019 showed a weak protective effect on mortality. So it's not a no-brainer to close an ASD in adults. Weak protective effect on mortality and no significant impact on atrial arrhythmia if the patients are older than 50. But still, there are indications for closure. And if there are symptoms, that's considered class 1 evidence. In asymptomatic, there's class 2A evidence on the basis of right atrial and a right ventricular enlargement, a QPQS greater than 1.5 without cyanosis at rest or during exercise. So I'm going to talk a little bit about the device closure. The device is a dual disc structure with a detachable cable, and it goes up through the IVC into the right atrium, across the defect into the left atrium, and the left-sided disc is open first, and then the right-sided disc is open to straddle the defect. So it's used for secundum defects, and you have to have sufficient rims. In other words, the wall around the defect, there has to be enough of it so that the device has purchase on the adjacent interatrial septum. There's also a size limit to the size of the defect. So when I wrote this, it was 4 centimeters. They're constantly, there's constant innovation, and different devices are coming to the market pretty readily. But if the defect is too large, it won't be amenable to device closure. We also look at the rims, the retroaortic or anterior superior rim. The anterior inferior rim is the relationship between the defect and the tricuspid valve. The posterior, superior, and inferior rims are the relationship of the defect to the SVC and IVC, respectively. So this is an example of a secundum ASD closed by a device. So transesophageal echo is, even sometimes transthoracic echo is used to size the defect. We can do it on CT or MRI, but as I mentioned before, the interatrial septum can be difficult to image, so it's less good. And in any event, basically on all occasions, the defect is sized during the procedure by a balloon prior to device closure. And here we see a fluoro image, and we can appreciate the device on the right atrial side, the first disc, and then the second disc is opened on the left atrial side. And I'll show you some images of that radiologically. This is a 32-year-old woman at this time who had had a ASD closure device 6 years earlier. So when we look at the pre-procedure, pre-closure radiograph, we see the typical appearance of shunt vascularity. We see very prominent central and peripheral pulmonary arteries. And even as you go out to the periphery of the lung, we see pulmonary arterial overcirculation. Now, 6 years after device closure, we can see the return of the pulmonary vasculature to a normal, or depending on how severe the shunt is and how old the patient is, or a more near normal appearance. And this is the device on the chest radiograph. Even though it's this big double disc device, it's not super obvious when you just glance at the X-ray, but here we see the dual disc structure that's well positioned. And this is its appearance on CT. And the two discs are oriented parallel along the interatrial septum. And as it endothelializes, the shunt is closed. Here we have a 55-year-old man who developed dyspnea on exertion. He underwent an echo at that time. So this is also an adult diagnosis, and which showed right-sided cardiac chamber enlargement and suspected an ASD. He underwent MRI, and on this MRI, we can appreciate this is a short access through the interatrial septum, and we can appreciate the Secundum ASD. On these still images, we can see the defect better through the interatrial septum. We can also appreciate that the right ventricle is somewhat dilated, but it remains thin-walled, so without evidence for pulmonary hypertension, and that was the case hemodynamically as well. When we look at the retroaortic rim, the anterior superior rim, we can appreciate that it's actually quite small, and that was corroborated on echo as well. And so for the MRI results, we found that the QPQS was 1.4, which is kind of borderline, right below the threshold for closure. And we found the deficient retroaortic rim. We looked at the biventricular systolic function was normal, but the right ventricle was somewhat dilated, and a decision was made to treat the patient with patch closure because the anatomy wasn't suitable for a device closure. So what are contraindications to closure? The main contraindication in general to closure is Eisenmenger syndrome, which is irreversible pulmonary hypertension. And these people have very elevated pulmonary vascular pressure with right to left shunting and cyanosis. And they may have clubbing. They have systolic pulmonary artery pressures that are more than 50% of systolic systemic pressure, pulmonary vascular resistance greater than a third of the systemic vascular resistance. So we can't close it, but with medical therapy, many of these patients can have a somewhat, a decent survival over years. So it's not necessarily a death sentence immediately, but a lot of the cases that we see presenting later on, they do not do well even in the short term. Here's a 44-year-old man who had chest pain and dyspnea, and we can see that his heart is markedly enlarged on the chest X-ray. When we look at his pulmonary vasculature, the central pulmonary arteries are prominent, but there's some pruning of the peripheral vasculature. And that's a warning that even though there's shunt vascularity, because we see prominence of the vessels, we'd be concerned about pulmonary hypertension. And he went for a chest CT to evaluate for pulmonary embolism. This is what we see in our ER patients. And there was no pulmonary embolism, but here on the images through the heart, we see that the interatrial septum is basically absent, and we can see the contrast kind of falling between the right atrium into the left atrium. The right ventricle is hypertrophied, right atrium and right ventricle are dilated, and the central pulmonary arteries are peripherally calcified, and that's indicative of systemic arterial pressure. It's thought to be really basically atherosclerosis of the pulmonary arteries. And so this patient clinically had Eisenmenger syndrome and was treated medically. Switching to the Primum ASD, here we have an X-ray of a 53-year-old woman who had no history. She presented to the emergency department with shortness of breath. Shout out to my colleague, Ben Zolter, who read this X-ray from the ER. And he said the heart is big, the central and peripheral pulmonary arteries are big, and he suspects that the patient has an ASD, recommended an echocardiogram. So instead of doing an echocardiogram, they did a non-contrast chest CT for some reason. And on the non-contrast chest CT, this is the interventricular and the interatrial groove, and you can appreciate how markedly dilated the right atrium and the right ventricle are, as are the pulmonary arteries. And then for some reason, they decided to send the patient next for a cardiac MRI. And this is a horizontal long axis cine image through the heart. First, we can look at the cine images. We can see that the area of the fossa ovalis where a secundum ASD would be, it is intact. However, there's an interatrial communication low down at the level of the primum defect. You can see the left to right flow through that defect. We also see a dephasing jet of regurgitation, and these two valves are at the same level. And typically, that's the AV valves are not called the tricuspid valve and the mitral valve in a primum defect, but rather they're called the right AV valve and the left AV valve, and we see regurgitation of the left AV valve. This is the defect, low in the interatrial septum. When we evaluated the pulmonary and the aortic flow, we found a QP/QS of 2.2 to 1. So surgery was indicated, and the surgery for Primum ASD is usually patch closure. It can be sutured closed depending on the severity of the defect, but it's important to look for associated anomalies, including VSD, which in the setting of endocardial cushion defect, it would be a component of the same defect. The other thing that we have to remember is the cleft in the anterior leaflet of the left AV valve, or many people still call it a cleft anterior leaflet of the mitral valve, as we see in this case. And that's important for preoperative planning to make sure that everything is addressed at the time of surgery. Here we have a 76-year-old woman. We're segueing now to the sinus venosus defect, who came in with no prior history except for atrial fibrillation, and she came in for an ablation, and we did a CT for pulmonary vein mapping. So when we do the CT for pulmonary vein mapping, we look for the insertions of the pulmonary veins, of their locations, and the left atrial appendage, and we want to make sure there's no anomalous pulmonary venous return. And here, so let me just scroll through. What we can see is here's the normal appearance of the right inferior pulmonary vein and the normal insertion of the left inferior pulmonary vein, and the left superior pulmonary vein is also inserting normally on the left atrium. This is the right superior pulmonary vein, and we see the superior vena cava. And the right superior vena cava is in communication with the superior vena cava is in communication with the right superior pulmonary vein. And as we scroll down, what we see is that there's a relationship. Basically, there's a defect in the sinus venosus with relationship between the left atrium and the right atrium at the SVC right atrial junction. And there's marked dilation of the right atrium, as well as right ventricular dilation. On these selected axial images, they just show those 2 points. And we also do reconstructions whenever we see anything that looks funny. And you can see that this is really the hallmark of a sinus venosus defect, is that the SVC is related not only to the right atrium, but also to the left atrium. And this is the defect in the sinus venosus itself, right? The SVC should only be related to the right atrium. When we look at these reconstructed images to look for pulmonary vein insertion, we see that the right superior pulmonary vein enters the lateral aspect of the superior vena cava. And here we have another person with a sinus venosus defect, 43-year-old man. He had an abnormal EKG, and he actually came for a cardiac CT on his X-ray, everyone's starting to recognize the shunt vascularity, very prominent and very sharp central and peripheral pulmonary arteries. On his cardiac CT, the right atrium and the right ventricle are dilated. And we see this defect in the sinus venosus with communication of the left atrium and the right atrium. This characteristic relationship of the SVC, not only to the right atrium, but to the left atrium. That's typical for a sinus venosus defect. And we see here the right middle lobe pulmonary vein is entering the atrium at the level of the defect. And the right-sided PVR is an integral component of this anomaly. And one of the important things that we need to do when we do a CT or an MRI is to look for all of the veins, including accessory veins. For example, in this patient, there was a right upper lobe accessory pulmonary vein entering the superior vena cava very high up and laterally, and another right upper lobe vein, and then the right middle lobe vein is seen here. So they all had separate connections to the superior vena cava. So the treatment is the Warden procedure, and identification of all the pulmonary veins and their drainage is crucial preoperatively. And if you have a high up vein, it's important for the surgeon to know what its relationship is with the azygous vein, because in the Warden procedure, the SVC is transected above the anomalous veins and anastomosed to the right atrial appendage. And the anomalous pulmonary veins are baffled to the left atrium. So it's not a straightforward procedure, especially in cases where there are multiple pulmonary veins, including ones draining high up. And it can be complicated. Of course, usually it goes smoothly, but it can be complicated by SVC obstruction or SA node dysfunction. The unroofed coronary sinus, as I mentioned before, is it's not a true ASD, but it behaves like an ASD, and it's actually a rare anomaly. And here we have a patient, 55-year-old woman who had breast cancer, and she had a CT chest, abdomen, and pelvis to look for metastases. Luckily, she didn't have any metastatic disease. But when we look at her CT scan, we see the right atrium and right ventricle, and the right-sided cardiac chambers are larger than the left. So there's clearly something going on the right side. The right ventricle is very thin-walled, no pulmonary hypertension that we can see. And it's usually the thickness of the right ventricle can be a very important clue, even on a non-gated CT, as to whether or not pulmonary hypertension is present. Here we see the left ventricle. And this is actually not the left atrium. This is a markedly dilated coronary sinus. This is a straight sagittal reconstruction because this was a diagnosis that we made retrospectively from the chest, abdomen, and pelvis CT after we'd lost our primary data to do fancy reconstructions. But we can see there's the spine, here's the aorta, here are the pulmonary veins in the left atrium, and this is this markedly dilated coronary sinus under the left atrium. And normally it's much smaller, and there's an intact roof between the coronary sinus and the left atrium. And here they're pretty much in free communication. And here we can appreciate it on the coronal reconstructed images. And this patient was completely asymptomatic and didn't undergo treatment. Here's a case, this is really pertinent because it had a cardiology presentation. 58-year-old man, new onset atrial fibrillation, and a decision was made with indication for ablation. And we did a pre-ablation CT, and during the CT, we noted there was mild dilation of the right-sided cardiac chambers, and we saw a prominent coronary sinus, and we looked pretty carefully for what the reason is. Was there a left SVC? There was not. And we looking for a defect in the roof of the coronary sinus, and there was like an artifact here, which made us uncertain. And the patient underwent the procedure, and the catheter went through the coronary sinus into the left atrium during the procedure. And so we went back and we looked harder to do reconstructions, and there's still that artifact there, which makes it was really not possible for us to prospectively make the diagnosis, I think, except given that the high index of suspicion from the markedly dilated coronary sinus. But this was in fact the defect on additional imaging, about 13 millimeters. And it presented with AFib later on in life. So what about the patent foramen ovale? This is currently a kind of a hot area. And I have my feelings. I'm going to express them. People may disagree with me, but it's a remnant of the normal fetal circulation. I don't think that's contentious. And it's a flap valve with overlapping of the septum primum and septum secundum. So on this CT scan, here we see the SVC, the IVC, the right atrium. This is the left atrium, and this is the flap valve. So we basically the opening on the left atrial side is higher, and on the right atrial side it's lower. And in about 25% of adults, it doesn't close. So 75% of the time, approximately in adults, the fossa ovalis is closed, the flap valve has closed, and in about 25%, it never closes in life. The atrial septal aneurysm is highly associated with the PFO. It doesn't have to be present when PFO is present, but if the aneurysm is present, PFO is very likely. And it occurs when the septum primum is thin and mobile, and we can see an example of that here. This is an atrial septal aneurysm in someone who has a PFO, and the left-sided cardiac chambers are opacified with contrast, and we see some left to right flow through the PFO. And what we know from imaging is that occasional shunting in the presence of a PFO is nearly universal. And we can see it on gated CTs, we can see it on non-gated CTs. It's actually very hard to see unless there's a very large PFO. It's harder to see it on MRI. This is another CT scan. This is actually nice because we can see that the SVC is related to the right atrium and not the left atrium. This is where the sinus venosus is. And we see the flap valve of the fossa ovalis. And this can be distinguished from a secundum ASD because in a secundum ASD, there's a direct communication between the two atria. It goes straight through. You don't have a tunnel like you have with a PFO. And here we see the left to right shunting of contrast. This is from an axial non-gated CT. And here we also can see shunting of contrast, but in this case, it's right to left. We see the dropped contrast from the right atrium layering along the interatrial septum and going through a PFO into the left atrium. So what I'm going to say is that anything with 25% prevalence in the general population is not an anomaly. And I don't think that when you make that broad statement that that's controversial, but there's a lot of attention being brought nowadays to PFOs, and there are associations between PFO and variety of pathologies. So PFO is probably like somewhat globally a risk factor for different things, including paradoxical emboli, cryptogenic stroke, migraines, decompression sickness, high altitude pulmonary edema, and population studies of people who have these illnesses show a higher prevalence of PFO. But when you look at the broader population of people with PFO, their risk of any of these particular events is actually very similar to the general population. So it's a very, very low risk if you are an asymptomatic person with a PFO. Nevertheless, there have been, cryptogenic stroke is a really big problem. And there has been hope that treatment for cryptogenic stroke for people with PFO, that patients would benefit from closure. And a bunch of randomized trials of percutaneous closure versus anticoagulation, antiplatelet therapy were undertaken. And many of them were underpowered, but in aggregate, they basically have shown a superior outcome for secondary prevention of cryptogenic stroke, especially in people who have an atrial septal aneurysm or a large shunt. So in the setting of cryptogenic stroke, PFO closure is is a current standard and it's indicated. And the FDA approved the PFO occluder in 2016. And after that, it's really taken off as a more common procedure, and we see it more often. So what are some complications of device closure? Device closure is very safe and it's beautiful, but nothing is without complications. And this is an example of a 24-year-old who had sickle cell disease, who had stroke and a PFO, and who had a device closure. And here we can see that there's low attenuation on the device itself, and that was like a vegetation on the device. And they developed septic pulmonary emboli. There were pulmonary emboli also within the lungs. So this is an example of a rare complication from device closure. You can also occasionally have other problems, including embolization of the device itself or thrombosis. You can have erosion, and erosion of the device into the aortic root has been a reported complication for adults who have ASD closure with an inadequate retroaortic rim, although newer devices are thought to be less risky. You can also have erosion through the atrial wall. You can have rupture, pericardial tamponade. And then, you know, sometimes the device, if it's not deployed properly or it malfunctions, it may be malpositioned. You may have residual shunt if it's, if for various reasons, including positioning or difficulty in estimating the size and the shape of the defect. Or you can also have coronary sinus compression if the device reaches the coronary sinus. These are all uncommon complications that have all been described. So in conclusion, and I have a couple of little cute cases at the end, just these few. ASD in adults is a milder disease spectrum exacerbated by comorbidities. I've reviewed the typical chest radiographic findings, and this is something that we all should think about, whether radiologists, cardiologists, or physicians in practice. If you see very prominent central as well as peripheral pulmonary arteries, if the central arteries are dilated and the peripheral arteries are pruned and the lungs are black, we think pulmonary hypertension. If the central vasculature is prominent and there's haziness around the vessels, we think CHF. If the central vessels are prominent and the peripheral vessels are also prominent and they're very sharp, we think pulmonary overcirculation secondary to an undiagnosed shunt, and that we may help the patient in that way. CT use, as you see, we often do CTs for pulmonary embolism in people with nonspecific symptoms, and we have the opportunity to make a diagnosis of an unsuspected ASD. I actually had such a case last week. If we know that there's a defect, or if we have echocardiographic evidence for right-sided cardiac dilation, we might want to do an MRI. That's the best study to look both for the anatomy and to best estimate the ventricular volumes to directly measure shunts. We can do MRA to look for associated venous anomalies. And CT, I would say, would be a second choice if MRI is not feasible because we can't directly measure flow. And our volumetric estimates for ventricular volumes are A, technically more difficult to do, and B, a little bit less accurate and reproducible. So here we have a patient. This is a lateral scout from a CT scan. The patient obviously had a sternotomy, they had a CABG, they had an aortic valve replacement, and after that, they had a pacemaker placed. And we see this pacemaker going down the SVC and going posteriorly into the left atrium and the left ventricle. Here we see the left atrial pacemaker lead. So this is a person who had all of this cardiac surgery, but had an undiagnosed sinus venosus defect, which led to pacemaker malposition. And this is one of the most giant ASDs ever with device closure. And basically, this is the right atrium and this is the left atrium. So the biggest ASD ever. Okay, thank you. Any questions?
Thank you very much, Linda. That was great. I think, and I always tell fellows how important it is to become familiar with X-rays, in particular for the scouts, right? That as cardiologists, we need to be able to read the scouts properly. The pictures were beautiful. I think one question, and I'll start with one question, and please put the questions in the Q&A, and then we'll go through them. What do you recommend to get such beautiful pictures? Do you ever switch to a test bolus, or do you ever tell patients to do the acquisition during expiration or with a sharp inspiration? What advices you have for the acquisition?
For CT?
Yeah.
So when we're doing when we do a cardiac gated CT, to look for a shunt or to look for basically any like cardiac CT for anomalies, we always do a test bolus. And what we look for, because we want to see both the right side of the heart, and unlike a coronary CTA where we want to evaluate the left side of the heart predominantly and the coronary arteries, with congenital anomalies, the right heart is always very important. So we need to opacify both the right and the left heart and the aorta and the pulmonary arteries, so that we do a timing bolus, and we try to pick a time that has good opacification but differential opacification of the right side, right and the left heart, so that when we do volumetrics of the ventricles, if both ventricles are exactly the same amount of enhancement, it's technically almost impossible to, like, for example, if you want to measure the stroke volumes and the function for both ventricles, we need to have differential opacification. It depends on the question that we're asking if we preferentially want to have better opacification of the right heart or the left heart. So we tailor it to the specific indications. But for the congenital cases, we almost always, I mean, we always do a timing bolus for congenital cases. And we tailor it. We usually will also give more contrast. We tend not to give a saline flush because we really don't want anything flushed out. We want everything opacified.
That's great. That's great. And any sequences you think that should definitely be used for MRI that would help you? And
so, I mean, again, it depends on the questions, but I mean, we always want to do the pulmonary and aortic flow so that we can do a QP-QS if you're contemplating a shunt, because that's one of the, it's one of the primary indications for treatment. And while we can also use the stroke volumes to estimate the shunt fraction, if there's any valvular dysfunction, it becomes so much less reliable. We also always will do an MRA rather than doing a perfusion and viability. We're always going to do an MRA for the contrast during the contrast injection, so that we can evaluate the venous and arterial, extracardiac structures, and make sure to have a big enough field of view to do so.
That's great. I think there's no questions, but I would ask. We saw recently a patient that was not a candidate for surgery actually, and we ended up closing an ASD because it was severe RV dilation. Have you seen recovery from these big RVs after closure? Or when would you recommend re-imaging, and what modality?
So I don't think there's a strong evidence base for that. We know, like, from tetralogy of Fallot, which is a different process. If you, but with TET repair, many of the repairs, even modern ones, but especially the older ones, if we see them in adults, they have a lot of pulmonary regurgitation, and so they have right ventricular volume overload. And the decision, this is like in TET world, this is like the big question is, when do you fix the pulmonary regurgitation? Because you want to get the timing just right so that it's not too early, because they have congenital heart disease, and you don't want to operate more than necessary, and you don't want it to be too late. But one of the things that we know is that the dilation can goes down when you fix the volume overload, but the function does not recover. So it does. But in terms of ASD, which is a much less morbid condition, and adult presentation is often, it could be like atrial arrhythmias. AFib is like a common adult presentation, and pulmonary hypertension much less commonly. So we know based at least on that systematic review, that aggregates the evidence that if you close it really late, you may not have any chance to impact the atrial arrhythmia. And it's much more mushy. The evidence base is not good yet for when to close it. And we're doing more and more closures because instead of needing open heart surgery, there's availability of devices for amenable cases. And so I think that probably it's going to have to take like population series over time is going to be, because no one's going to do a randomized clinical trial of it. And with all congenital things, it's compared to coronary artery disease, every congenital lesion is a rare event. So it's hard to get sufficient high level evidence for treatment. So the best thing is going to be like case series over time, and it's going to take a long time to find out because the patients typically have a good natural history.
That's great. No, you answered perfectly. Okay, so if we don't have any more questions, we'll close here. Thank you very much for your time. That was we learned a lot. It was very good. And okay, thank you very much.